welcome everyone. My name's Dr. Liz Grier, and I'm a family physician from Kingston, Ontario, and I'm pleased to be joined by two colleagues, Dr. Ullanda Niel and Dr. Samantha Sacks. And you know, it's been wonderful today, but a bit intimidating for us to hear fantastic speakers whose papers we've read over the years, etc., come up to the podium and say, I've been working in this field for 20 years, I've been at this for 30 years. We've been at this probably about 5 years, and we're part of a newer generation, though, which is an exciting thing, which is family physicians who are completing additional training beyond the 2-year core residency in care of adults with developmental disabilities, and bringing that special interest in our practices with hopes of contributing to generalist family medicine, and an area where we have no equivalent specialty. So in pediatrics, we have developmental pediatricians and general pediatricians who do a lot of care of individuals with developmental disabilities, but there isn't really an equivalent Royal College specialist who takes over in adulthood. And so it comes to the family physician. And I hope that I'm able to emphasize today, as we go through this particular group of patients with ASD, that there couldn't actually be a better person to be involved right from diagnosis in the toddler years through into adulthood than the family physician and their associated primary care team, which we look at more broadly now as the patient's medical home, and so we'll talk about that today. These are our learning objectives, so we'll talk about this tool called the Autism Health Watch Table that's meant to help us guide our primary care for these individuals with evidence-based recommendations or consensus recommendations. We'll learn to anticipate and manage common genetic, gastrointestinal, and neurological conditions. We'll talk about specifically, we're going to just take a snippet out of something that we've been seeing quite a bit in our clinics, which is managing women's health conditions. I know that it's of lesser prevalence in women than in men, but there's certainly some particular things that we'd like to highlight where we feel family physicians already manage these areas well in our practices and can particularly contribute to the care and well-being of women with ASD. And then we'll talk and have a great presentation by Ullanda about some ways of facilitating, bridging this transition from pediatric to adult care. This is a busy slide, but this is, I think, a very important resource both for advocacy but also to help us set the stage and framework for caring for patients with autism spectrum disorders in our practice, and that is the definition of the patient's medical home by the College of Family Physicians of Canada. And these are the different points. I won't go into them in a lot of detail, but we're going to come back to them at the end of our talk, and we're going to put the lens on these recommendations in terms of what are the accommodations that we need to make for our patients with ASD in our practices. So we talk about the patient's medical home for everyone being patient-centered, that everyone has a personal family physician who's the most responsible provider, and I often talk about us being the quarterbacks of the medical care for the individual. We offer a broad scope of services, but it's within teams of a range of different providers, that there's good access to appointments, as well as advocating for specialist appointments as well. There's a comprehensive scope of family practice services offered within the home. We use electronic medical records to maintain data at a high level of quality. We train medical students, and we do training for family medicine residents, and we offer research through these centers. We have a commitment to evaluating and making sure we're doing a good job and contributing to continuous quality improvement. And lastly, we're supported by the administrative structures we need within our primary care medical homes, but also by external government and other stakeholders. So we'll come back to these and we'll think about, this is all great, but what do we need to specifically think about in order that we offer this effectively for our adults with ASD? Thank you to those of you. There may be some in the audience who participated in this survey that went out through the Ontario Medical Association, both to psychiatrists and to family physicians. I'd like to summarize it really quickly. This is the data from family physicians. So more than half of family physicians say that there's more than 1% of patients in their practice over age 16 who have ASD. So that's really a significant number. We're, again, up in the range of some types of prevalence, type 1 diabetes, schizophrenia. We're up in that range, so we need to think about this perhaps as more common than we realized. The bulk, though, of where we consider these patients to be in our practice is still under 26. So it's this a group that are moving through and transitioning into adult years. Most are living with families still, and that's different than it would have been likely 20 years ago. And the bulk of patients are not in a school or employment situation. What supports do family physicians need? There's strong, resonance here that we don't have the tools and the referral resources and the types of models that we need to provide this care. It can be difficult for individuals with ASD to participate in their care or for their caregivers to participate in care. We feel we have average knowledge and skills in being able to provide this care, and we also feel that in correspondence, there's somewhat of a dearth in terms of the resources for learning a bit more. So what would you like to see? The family physicians want evidence treatment approaches. They want to talk about both the physical and medical issues as well as mental health issues and psychotropics needed to treat patients with ASD. They'd like to know more about communication. Where are the resources and the network of providers that we need? How do we screen and diagnose ASD? And what's the access to specialized clinics, either in primary care or in dual diagnosis? So this was the survey of a number of family physicians in the province. What do we know? And I think this has been really touched on already today, looking at quality of life indicators. This is the Howland study that Dr. Volkamar mentioned earlier today. High rates of identifiable mental illness, 88% of patients at least on one medication. The lesser number are in an educational or work program. Low rates of marriage, low rates of identifying of having at least one friend. But I think that it was a very resonating point for me today that we need to continue to evaluate this. We need to continue to evaluate what we consider to be optimal outcomes in this population, but certainly reason for concern regardless. And the opportunity to do more. The ASD affects 1.1% of adults on average, and this is a statistic from the United Kingdom, and we'll go through a set of the guidelines that have come out of that country, that for every 3 known adult cases, there are at least 2 individuals without a diagnosis in adulthood who will benefit from assessment, support, and intervention. So who will be the first point of contact for this group of patients? Well, it will be the family physician. So we do need to be thinking about surveillance for ASD. We need to be thinking about how we go about supporting and getting the diagnosis. Here are some recommendations. We know a lot, we talk a lot about the absence of certain developmental milestones or the positive signs of autism in toddlers and young children, but how does this translate in adulthood, and what are some of the things we might be looking for in our adults in our clinic? So persistent difficulties in social interaction and communication, the stereotypic behaviors and resistance to change or interests, but what does that actually look like in adulthood? We're not talking about playing or pretend imitation. What are the things that this manifests as in the adult arena? And so these are things like problems obtaining or sustaining employment or sustaining social relationships, persistent or current contact with mental health or learning disability services, and a history of a neurodevelopmental condition like learning disability or ADHD or mental disorder. The Autism Spectrum Quotient is in the handouts, and it's a simple 10-item scoring tool. If there's a score of 6 out of 10, then that would be something simple we can use as an indication to refer for diagnostic assessment. I really like this slide, and this is also from Dr. Howland, and it goes through a way of conceptualizing ASD that I think is very helpful. So it talks about core impairments, it talks about other common features, stereotype behaviors, the need for routine or special interests, common associated problems like sleep and sensory issues and dietary issues. And then on the very far outside, looking at concurrent developmental disorders, ethical issues, risk issues in terms of capacity, mental health and challenging behavior, and then physical health issues, which we'll touch on today. But I step back and I look at this and I say, well, awful lot of this is stuff that we do in family medicine. We might be pretty well suited to be able to have conversations around this with patients and their families if we look at the very big picture, the longitudinal picture for the individual. We'll come back to this because we'll just list our resources at the end, but by far and away our understanding of autism and the ways that caregivers can support people with autism has been very much enriched, if anything, very much changed and forwarded by self-narrative accounts. I find Judy Endo's, and I apologize if I'm saying her last name incorrectly, but I've read her blogs numerous times, and I would really encourage the clinicians in the room to read these, or everyone to read these. They provide a very, very insightful self-narrative that I think can be most helpful for us in our interactions as we support our patients. And there's a few other recommendations there as well. It's important, we feel as well, to identify comorbid health-related conditions in people with ASD, and this is a great role for the family physician as well. Today, Dr. McDougall talked about the host of specialists that are available to him, it seems like, just as he needs them in his multi-professional clinic in Massachusetts. We don't have those types of teams and access to specialists nearly equivalently here in Canada, and there's a fantastic role, though, for the great access that we have to family physicians and primary care professionals to be able to look for, identify, and at least begin treatment of optimization of these comorbid health conditions. The Autism Treatment Network has provided us with advice, and this has been well over 10 years. This project has been in place looking at important comorbidities in ASD. But there's challenges in the assessment and diagnosis of physical health comorbidities, difficulties tolerating physical exam. Individuals who are nonverbal or have limited verbal communication or have difficulties with sensory processing may have difficulties reporting pain or localizing discomfort for us. And we can also see atypical presentations of physical symptoms presenting as aggression or self-injury. There's this is the tool that I was referencing on the Surrey Place Primary Care website, and we'll come back to it throughout this talk. We're fortunate to have Dr. Bradley, who is the lead contributor in the room here. May I point you out there? Thank you, Elspeth. Perhaps it can flesh out some additional questions if people have them about this tool. But it is anticipatory guide for primary care of children and adults with ASD in the Canadian context, and it's available here on the website. It's a 20 to 25 page resource. There's a lot of detail. You can look at it on paper. You can also look at it online, and all of the links have been checked and are still working well to get to different resources for clinicians, resources for parents. It's a big document, but it's all contained there. And then the first page of the document functions as a checklist for your annual encounter for a patient with an ASD in the office. And so we'll walk through that. Let's start with our case here. So we'll do something a little bit interactive to bring things together. So we're going to be asked to see Susan. She's a 17-year-old woman in your family practice to renew one of her medications. You, as the family physician, know Susan's mother because she's your patient, but you don't see Susan often as she's mainly followed by her general pediatrician. You know that she lives with her mother and stepfather full-time and that she does require 24-hour supervision and support for almost all of her activities of daily living. Your file indicates that she has diagnosis of autism spectrum disorder and intellectual disability. She's got no allergies or history of hospitalizations or surgeries. Her medications, according to your file, are risperidone 1 milligram 3 times per day and Restoralax 1 tablespoon daily. Her mom has come requesting that you renew the Restoralax so that it will be covered under their drug plan. So we'll maybe open things up here. Are there things that you'd like to know more about Susan? Anything people would like to know?
How is her life skills, or how is her presentation in school?
Yeah. Great. So what is her level of functioning? And you've mentioned intellectual functioning, but also alluded to adaptive functioning. How is she managing in school? Great. her interests. Yeah, no, absolutely. Getting to know her a little bit more. Have those been looked at? Is there support in her education environment in terms of her interests? Yeah, what are the support? Yes. So certainly looking at protective factors like we talked about earlier today. Great. Yes. Great. Yeah, great. Good. Why is that? Good. Good. Yeah. Yeah. Great. Good. Are there any investigations or interventions you'd like to suggest? This is hard to know. Yeah. Yeah. Any types of support we could put in place. And so, yes, let's go through some of these questions here, because I look at this and think, oh, I've got 2 diagnoses, but I've got 2 medications, and I actually don't see that either of those diagnoses are indications for those medications. And this patient is 17, and I know the rest of the family, but I may not know her as well as I would like to. So what are some baseline information that it would be helpful to try and get our hands on? It may be out there, but just not part of our file or our cumulative patient profile for this patient. So the genetics assessment, 10% of cases of ASD are associated with chromosomal or genetically determined disorders, and that number is actually likely higher as we've listened to Dr. Satmari present to us this morning. And there is now a solid recommendation, and perhaps I can just a survey of, has anyone in the room who's perhaps not a geneticist by trade ordered a microarray for a patient? They have experience doing that? Yeah. Okay. So yeah. So this is something that's new, but will be recommended to primary care providers often as an initial test in the process of referring to genetics. So ordering a chromosomal microarray, and on that website we are working on updating a genetics tool. That tool is mainly focused on the rationale for genetic assessment in autism or intellectual disability, and that is going to be updated to talk a little bit more about counseling and ordering microarrays as an initial step to referral to genetics. And of course, Fragile X testing, which is a separate test to the clinical microarray, also benefits from being completed. A psychological assessment. So this is right from the Autism Health Watch table and provides the exact wording from the table. So I'll let you look at that in a bit more detail in your slides. But it emphasizes the importance of having a sense of the person's cognitive ability and, of course, adaptive functioning as best as we can. Not only to just know what it is, but most importantly, in order to ensure that our supports are being tailored to the individual's needs. Are they being under-supported, or is there opportunity for them to be actually more independent, depending on their skill set? And so the recommendation to refer to a psychologist for assessment and to revisit those referrals if need be, if there is a change. So if there is a worsening of behavior, if there's a transition that is anticipated, to be able to revisit that psychoeducational assessment. Our guidelines recommend every 5 years or when indicated. And we realize that that's a tall order. People are shaking their heads in the audience, but we feel that it's important to set this as a standard and emphasize the importance of having an accurate assessment of the individual's needs and strengths. Communication is also something that's important, and understanding how the individual communicates their needs, also communicates pain, is something that we'll talk about in a little bit as well. But we benefit from a speech assessment, and there's actually lots of ways, as Dr. McDougall alluded to in our earlier session, of looking at communication outside of verbal communication, of course. And so this goes over referring to a speech-language pathologist or other provider, and also what to do in the event of language regression and some additional tests that should be considered. And again, this is all in that big document, the Health Watch table. Hearing, we recommend being assessed on a regular basis, not just at diagnosis, because there are higher rates of hearing impairment in this population. We also recommend assessing vision impairment on a regular basis. Certainly finding audiologists and optometrists or ophthalmologists who provide an autism-friendly environment and work creatively with our patients is important. We try to network together to find out who those individuals are, and so asking other patients or families in your practice about who is particularly accommodating can be a way of finding out a helpful resource for another family. And likewise, while difficult to do dental care, sometimes it's very important to continue to advocate and creatively work around trying to access this. Certainly higher rates of caries, poorly treated caries, for example, tooth extractions rather than restorations in this group. So very, very important area that we can check in on our annual review. We can see motor difficulties in this group, and I won't go into this but because it's in the Health Watch table at length, but this can be particularly important consideration when we look at something that's very important to do, which is to encourage physical activity in this population, both for children and for adults, and there's a relative lack of physical activity, so important to accommodate any motor issues in that. And so this talks about the indications for referral for physiotherapy, occupational therapy, etc. And of course, if we see any kind of regression in skills or motor development, then we should consider neurology referral and perhaps some additional imaging related to that. Gastrointestinal disorders, and this is a big area for us and well worth screening, and the Autism Health Watch table recommends that we screen for both upper GI and lower GI issues, and we can certainly see rates, a 9 to 70% range is obviously a difficult one to get our heads around, but certainly this is much more common than the general population. We can also see these conditions, and so the full range: chronic constipation, abdominal pain, chronic diarrhea, reflux, H. pylori infection and associations, and celiac disease at higher rates than in the general population, associated with self-injurious behavior and sleep disturbance at times, and can present quite atypically with behaviors that we may not readily recognize. So if something is new or meets this pattern, chest tapping, particular facial grimacing, a gulping or a repetitive burping noise is something that I've seen, seeking out of abdominal pressure. It's worth thinking of what is a very common set of comorbidities, which is those involving the upper and lower GI tracts. And constipation is a very, of those, probably the most significant comorbidity that we see. The causes are multifactorial. To date, we are not aware of any particular motility issue with the bowel itself, but rather that this stems from picky eating or stool withholding behavior, and then is worsened over time, certainly by the addition of immobility, but also of the medications that we use in this population. Certainly any of these red flags should, as they do with the general population, alert us to look for some other cause for constipation that is concerning, and we can aid this by behavioral therapy, including mobilizing that gastrocolic reflex after eating. But of the medications used to treat constipation, PEG continues to be the most gentle and effective long-term laxative that the pediatricians and we in the adult world are using for this group. And trying to stay on top of constipation proactively is important, while balancing all of the non-pharmacological or dietary things that we can do. Pain is very important to consider in this population. If not recognized, it can present after a great duration of time, and the individual has suffered without us recognizing these atypical experiences of pain, laughing, humming, singing, removing clothing, self-injury. We can get focused on the behaviors, and if we're not aware of how the individual typically expresses pain, then we can miss a very important underlying issue. I do want to highlight, and I think this is very important, that there's no evidence that people with ASD suffer any less from the presence of a noxious experience. We hear a lot about being pain pain tolerant or having a high pain threshold, and we have no true evidence that pain is any less noxious for this group than for the typically developing population. It's more a difference in presentation. And there are tools that can be used to monitor for treatment of pain, empirical treatment of pain in patients who are not verbal. I won't go too much into detail there. And then it was a very good suggestion about another common issue, which is nutritional and feeding issues. These often present in childhood, but it's important to know that it's unlikely that these behaviors will just simply be grown out of, and they can respond to behavioral therapy. But it's also important for us to be aware of the likeliness of this and to screen for it, and then to consider associated vitamin deficiencies, because they can be quite, it's not common, but we can see quite marked deficiencies in these areas. Sleep disorder, again, was touched on this morning, but a very, very common concurrent disorder, and it affects all of the different cycles of sleep. There certainly is a pattern, particularly in children, but we can see it in adults, of these periods of night waking, where the individual may laugh or talk and get up and play with toys, for example, or be awake and happy for a period of time. That can affect the whole family, though, and so it's important to screen for that. Treatment, of course, involves good sleep hygiene, ruling out other disorders like heartburn that are active at night. We recommend screening and asking a question about sleep problems for all people with ASD. And if ineffective still, the only medication that has evidence in ASD is melatonin, but Dr. McDougall this morning went through a few other options and his preferred approach there. Sensory processing disorder is also important to think about, and referral to an occupational therapist for a sensory diet can be very helpful. I think it's also particularly important to consider in terms of our clinical environments and how difficult they can be from a sensory perspective in terms of the noise and the crowdedness of waiting rooms, fluorescent lights, the touch of physical exam, etc. So being aware of some of these sensitivities can make it just easier for the individual in our own clinical environments, which is affecting their access to care. So if we go back to our case now, let's look at the extra information that ideally we had. So we know her diagnosis of autism spectrum disorder. We know that from her psychoeducational report, moderate was the level of intellectual disability that was given, understanding that there's important variations. She has had a microarray done in the last year, and it was normal due to the presence of regression in the history, as well as comorbidity of intellectual disability. She had an MRI done of the brain in 2007, which was normal. And we've added additional diagnoses of sleep disorder, which we found out from the mother, constipation, and she is overweight with a BMI actually in the obese range. We've filled out our social history with some additional special information, so who she lives with, who's the anticipated decision-making capacity for her, so she's dependent for all supported decisions. Her mother is her substitute decision maker, and we've highlighted some special needs, which can be very helpful to communicate to other providers, and using our electronic medical records allows us to do that easily. So her communication is that she's verbal but has limited functional speech, a lot of echolalia, but she benefits from social stories, and that can be a way to engage and to teach and to communicate. She has difficulty with loud noises and fluorescent light. She's sometimes able to localize pain, but a better sign of pain is just agitation. It gives us an indication that there's pain somewhere. How to help when the individual is distressed. So this is a patient of mine, and by the time I've gotten to come into the examining room, she's normally written a few pages of sentences, and it's very helpful for her to be able to pull paper off of the printer that's sitting there and grab one of the pens off the desk and be able to write, and that's something that's calming while she's waiting. And so these are just sort of some things that we can document for the individual. Let's keep going with this case here. So we follow up a few months later after renewing the Restore-Relax and getting some additional information, and we get a report from the emergency department. And I was smiling as Dr. McDougall went through this case this morning, or this pattern that he sees, because that's certainly what this case shows. So Susan has had an isolated tonic-clonic seizure that was reported to last 45 seconds and has been brought to the emerge by ambulance. She's otherwise well, and there was no clear precipitant for the seizure. Her mother feels that 5 years ago there was an episode that wherein a babysitter was looking after Susan, where she fell down and started shaking, but some time, and it was difficult to get the history, and the emerge felt at that time that it was a fainting episode, which it could have been, but she was wondering if it was a seizure. So at her urging, an EEG and MRI are ordered, and a consult to neurology is placed. The wait is about 6 months to be seen. Susan's mother brings Susan to your office a week later, worried that she is showing more signs of agitation that remind her of how she was acting in the hours leading up to the seizure. What would you like to know more about how Susan is presenting now? So we've got a 6-month wait for neurology. We've got some tests that are pending, but a pretty good history of a generalized tonic-clonic seizure at about the time that we might expect this to emerge in the transition into adulthood.
Is there any changes after the seizure that, like sleep pattern, appetite?
Great questions. Yeah. So and so she did have a basic workup for infectious cause. Yeah. Electrolytes were normal. Yep. Great question. Good to do a full physical examination, make sure that there's no localizing neurological signs, etc. Yeah, great. And from what I could tell, that was normal, but it was a bit difficult to do all of the cranial nerve exams and other things that we would do, given her compliance with exam. Great question. Good. Yeah, no, that's one of the baseline questions that I'll ask. So seizure disorders are common up to 35% of adults and in children as well. Complex partial seizures are the most commonly reported, but we can see all types of seizures. Complex partial seizures can be difficult to distinguish from atypical body movements and behavior patterns seen in association with ASD in some individuals. And some may be due to even another medical condition, for example, like reflux. Any behavior, and we outline some here, like staring off or cessation of activity, eye fluttering, eye deviation, can be associated with seizures and should prompt an EEG. So Susan is seen by a pediatric neurologist a little earlier than the 6-month wait at your urging because of this change in her behavior, and she started on topiramate. She was slowly titrated up and had some difficulty at higher doses. Currently, for reference, she's maintained at 50 milligrams BID, which is certainly under the threshold that we look to get patients to in order to ensure that they'll have the most protection that they need, but we're slowly continuing to titrate that up. That was chosen in part because of concerns about weight gain with other seizure medications. But as mom is coming in, you've sort of lost track of Susan now because she's being followed by the pediatric neurologist. Her mom comes in for a blood pressure check and she says, Susan's doing so much better with these behavioral outbursts on topiramate, and she's sleeping a little bit better as well. Then a few months later, you get a call from the family. Susan has transitioned back to school after being off for the summer. She has a new classroom, physical classroom, and her EA has changed as well, and she's not doing well. She's having behavioral outbursts now at home and school and refusing to attend the activities she would normally enjoy, and swimming is a particular favorite of hers. Her mom was really not sure what to do, and so tried increasing risperidone to 4 times a day, and she feels that that's helping a little bit. The medication is therefore going to run out sooner than the pediatrician's prescription allows, and so it needs to be refilled, and she's requesting at this higher dose. The pediatrician is away, and so you're here to cover that need. So what more would you like to know, and do you have any concerns about prescribing this medication? What do people think? Right. That triggered this, yeah. Good. Yeah. Moved over, yeah. And not just the change in people, but the change in the physical space and the security of that environment. Yeah. Good. So we've not prescribed risperidone yet. It's been started and prescribed by the pediatrician. Any questions or concerns doing the medication? I think people would feel. And so this is a huge area, I think, that we need to be able to talk about, which is that family physicians inherit these prescriptions as these patients graduate to adult care. We were there at the beginning of the prescription, and our experience with prescribing atypical antipsychotics and other psychotropics in this population is relatively minimal because it's not a big part of our practice. But certainly we end up renewing these medications and responsible for monitoring them and their indication. So I'm going to, just in the interest of time, pop over these slides because they're really nicely captured in the earlier talks this morning. So this is just about the degree of mental illness in ASD, the extent of the psychiatric morbidity, and just the degree of rates of use of psychotropics that we see in this population, the importance of using very small doses and slowly increasing them with being careful to watch for side effects and also to include non-pharmacologic interventions. But I'd like to highlight this tool, and it's also on the One website. Everything is there, and it's got this orange background, and you just can't miss it. I know this slide's difficult to read, but this is a very nice checkbox tool, and I'd encourage it. Just looking at where things have gone with dementia care and geriatrics, I think that this is, we will see similar tools and suggestions coming out, or if we look at what happened with opioid and other controlled substance prescribing in primary care, we will see that with this group in that these medications are often being used off-label, and there are significant long-term side effects. So in the geriatric population now, I'm familiar with a consent tool that's used to be able to go over the risks and benefits of treatment and reevaluation of that treatment and its safety and indication on an ongoing basis, and affirmation that non-pharmacological interventions that are needed are in place. So this tool is a checkbox of looking through the important things. And what's the big one that's missing in this case? I've presented a lot of data, but I've not presented a diagnosis for risperidone in this case. And so certainly Dr. McDougall provides a compelling argument for looking at the important symptoms that we need to be treating. And as I looked at that, I said, well, those are going to be my new diagnostic categories. I will document that is the symptom cluster that I am treating if I inherit a patient like this, that at least there is some indication beyond saying autism that this individual is prescribed a medication. But I think it really warrants what has been done in terms of looking at transitions that may be affecting the individual or needs to support communication, identify pain and comorbidities, etc. So this is just 17 questions, and the tool is very helpful to look at the things that we need to be thinking about in terms of side effects. Yeah.
Did the pediatrician provide some background information how long she's been on risperidone and for what reason?
That's right. Yeah, exactly. So it was started around age 14 on transition into high school, and so it was started at the time of transition, but for the history of behavioral outbursts that were difficult to manage at home and at school. It's a high dose. Yeah, it was titrated up over years, but now it's a pretty high dose. So I'm going to pass things over to Dr. Sacks now to sec.
Okay, so to continue on with the case, you renew Susan's risperidone prescription at 4 times a day for 6 weeks, with the request that it be reduced down to 3 times a day once the adjustment to her new classroom has occurred. You ask that Susan be booked to see her pediatrician and also place a referral to the pediatric interprofessional mental health team. You ask in the interim that Susan's mother track the behavioral outbursts on a calendar and correlate to any physical symptoms or stressful life events. A few months later, Susan's mother brings her calendar to show you a pattern of behavioral outbursts that occur about day 24 of the menstrual cycle and last until her period starts. As soon as her period starts, Susan feels much calmer. Susan typically complains of stomach cramps for the first days of her period, and her mother has always been giving her Tylenol, which seems to help a little bit. What other information would you want to know, and how would this alter your diagnostic, treatment, and approach? Nothing at all? All right. So, as we see more and more women and girls transitioning into young adulthood, there seems to be more and more behavioral problems that focus around cyclical behaviors. And so a study that was done on women with developmental disabilities in general found that 18% of women with a developmental delay presented to their gynecologist or primary care provider with a complaint of cyclical behavioral changes. This was a large cohort study that was done of over 500 women in the US. And then it's found recently that women with autism were more likely to present with cyclical behavioral or mood changes compared to women with other developmental delays, including Down syndrome and cerebral palsy. So it's become clear that a significant number of issues affecting the quality of life of women with intellectual disabilities and autism revolve around the menstrual cycle, but there's still not enough information to really understand why this is happening. So just in terms of menarche in general, it's been found in the studies that it occurs in girls with autism at a similar age to their peers. Again, there are comorbid issues to keep in mind, whether it's the obesity that's common, that may be more prevalent, whether there are endocrinological abnormalities, or other comorbidities. For example, Down syndrome has been found menarche to occur at an earlier age, and cerebral palsy for it to occur at a later age. But oftentimes, during the transition age or when they're reaching adolescence, menstruation is an area that's overlooked when discussing with caregivers, with family members. And it's a normal physiological function that on surveys, families and caregivers have found that these girls receive very little education around. And it is a drastic change. If you're considering girls with autism who have certain routines or patterns, these dramatic hormonal changes and behavioral changes, as well as this new onset of bleeding, can become really, really distressing event in their lives. So in terms of neurotypical women, dysmenorrhea amongst menstruating women has a prevalence about 40 to 90% in the US, and it's one of the leading causes of absenteeism from school and work in teenagers and young adults. And most menstruating women experience at some point some premenstrual symptoms. Of these, about 20 to 40% consider them disruptive enough or severe enough to seek medical attention. And according to the DSM-5, 3 to 5% of the population will meet criteria for premenstrual dysphoric disorder or late luteal phase dysphoric disorder. So whereas women in the general population are usually able to distinguish between period pain and PMS symptoms, women with intellectual disabilities and autism are not necessarily always able to do so, especially if they have difficulties in comprehending and communicating. A very small study that was done in the early 90s found that women who were functioning at just the edge of normal intellectual functioning at an IQ of around 80 had very difficult times explaining what their menstruation was and what they felt at the time. So while unable to necessarily verbalize the symptoms, whether it's dysmenorrhea and cramps and pain or mood symptoms and PMS, they often become manifested as behavioral changes that are seen in a cyclical pattern. But often they're not necessarily recognized as such, and thus inappropriate either behavioral management or medications are implemented without the realization of what's the underlying cause. So very new and few studies are focused on autism specific. It has been shown that cyclical behavior symptoms are more common in women with autism than in the general population. The numbers are quite large, but in 2 survey studies done with family members and caregivers of girls with autism and women with autism, as well as those with high functioning autism who did self-reporting, 62.5 to 91% expressed that they had symptoms of dysmenorrhea, and 75 to 96% endorsed symptoms of PMS. One study that was done which showed quite drastic numbers found that 92% of women with autism fulfilled the DSM criteria for late luteal phase dysphoric disorder, compared to 11% from the control group. And this is one of the only studies that was actually done that had a control group to compare to, and they were using women with intellectual disability without the diagnosis of ASD. Several studies anecdotally will comment that cyclical changes in specific menstrual symptoms have been found. A few studies have found the ranges to be about a third of women will express these symptoms, and I'll go through those briefly. And in a single study that was done with a very small population size, the rates of premenstrual dysphoric disorder were at about 92%. So in terms of symptoms, common presenting complaints or behavioral changes included increased aggressivity, self-injurious behavior, and then these increasing autism spectrum symptoms, which would be increased stimming, repetitive behaviors and movements, as well as obsessive behaviors, restlessness or agitation, anger, social withdrawal, as well as the physical symptoms, which are often found, including headaches, constipation, back pain or cramping, nausea, breast tenderness, swelling, and bloating. So in terms of the diagnosis, it really depends on demonstrating true cyclicity of the symptoms, and therefore documentation becomes the main aspect of the diagnostic process. So daily charting, questionnaires for families and caregivers are very important. The one study that was done that was comparing women with ASD to controls of those with intellectual disability actually had caregivers in the group home that were blinded to the menstrual status of these women, and they did over 6 months tracking of behavioral changes on a daily basis. And so they were able to see these variations. And so the Surrey Place Primary Care Initiative, which is what we were discussing earlier, provides a nice table in terms of tracking menstruation over the year. But more importantly than this would be more of a symptom calendar of tracking behavioral problems. And really, the goal is to focus on the most troublesome behaviors and therefore the easiest to recognize. And by using a scale or a chart where you're able to objectively assign a number, you'll be able to see which behaviors are present normally and which ones are exacerbated during certain periods of the month, and be able to correlate that with the menstrual cycle. In terms of management, education is a key component that's lacking right now. Men are key preparation in terms of reminders, reassurance to the caregivers, advanced planning and discussion with them. Oftentimes, individuals with autism have expressed being able to see family members or caregivers, what they go through and how they plan and how they take care of their personal hygiene has been very helpful for them. There are also books and videos. There's a great one out of the UK called Janet's Got Her Period that uses pictures as well as simple text, and they've actually adapted it into, I believe, an app now to be able to help prepare girls for the start of their menstruation. And schedules, visual charts in terms of hygiene are very helpful. And really, by alleviating the confusion and helping the women to understand what their body is doing and create a routine around it, it's actually been shown to decrease some of the severity of the behavioral symptoms that are experienced in this cyclical pattern. From a medical or pharmacological point of view, ibuprofen and acetaminophen are the most commonly tried non-hormonal treatments for both dysmenorrhea and premenstrual symptoms in the general population, as well as in the population of women with ASD. What has been shown is that the regular use of NSAIDs, whether it be ibuprofen or naproxen, is helpful in alleviating or decreasing the symptoms, cyclical symptoms, in 65% of the patients, which indicates that perhaps there is a pain-like component, and this is the expression that these women are having of the pain. What's also been found in both general population and in the autism population is that many physicians don't necessarily provide appropriate dosing of the NSAIDs. And so what's suggested is to provide regular daily dosing starting 2 days prior to the onset of the symptoms once they're tracked, or the day when the symptoms are beginning, and to continue it until the last day of the menstruation. So it may be for 2 weeks a month that the girls or women are on NSAIDs, and as long as there are precautions taken to monitor to ensure that there are no side effects from that, it's really been shown to be quite beneficial. In terms of second line, hormonal manipulation, whether it's monophasic oral contraception or Depo-Provera, again, it depends on any comorbidities and the patient population to really see what's the ideal form. In the general population, there's been studies that have looked at certain forms of progestin which help more with the mood changes that occur. Hasn't been studied in the population with autism, but it's definitely a consideration to keep in mind. And finally, there's the use of antidepressants with SSRIs. And so again, in the general population, fluoxetine is an SSRI that is commonly used for the PMS or PMDD symptoms. There have been case reports of girls with autism where much better benefits have been seen with the use of paroxetine. But these are very few and more anecdotal in nature. But in terms of implication, it's always important to keep in mind a new onset of self-injurious behavior or aggression in early adolescence, to consider menarche and hormonal changes as being, so while changing to schools and all of the new events that were occurring in this patient's life, it's also important to keep in mind that maybe it is related to some of the hormonal changes that is going on. And as we've discussed earlier and throughout the day, the diagnostic overshadowing or considering these are the symptoms of the ASD as opposed to really looking as what might be underlying it. And associated psychiatric diagnoses which may be given and medications prescribed, which can either be found to be ineffective and thus discontinued, or the doses may be continued to increase when really there's this cyclicity of the behavior. And finally, the recognition of the cycle in relation to treatment plans. So whether it's implementing new behavioral management strategies, to start them at an appropriate time in the women's cycle, not initiating new medications or programming new changes in their lives during this preluteal or late luteal phase, or as well as other stressful situations. It's been suggested in some studies to avoid dentist appointments, invasive procedures until after the woman has actually passed this period in her cycle, as much better effects will be noted. Yeah.
Sorry, I'm not a doctor.
Yeah.
I'm just a person that doesn't know anything about this. So when you talk about first, second, and third line interventions,
Yeah.
do you think it would be better to avoid having the period at all by just having the pill with no breaks than it would be to go into an SSRI and pain medication if you could just stop the whole process?
Yeah, so depending on what it is, so certain methods of stopping the menstruation may not change the cyclical nature of the hormones, and so some of the symptoms may actually still be present even though they may not be menstruating.
So you'd still have pain?
You can.
So would that be something worth looking at in a person with this kind of profile, or would it just be, no, let's try Tylenol first? Okay, now let's try the pill and Tylenol. Okay, now we're just going to go to an SSRI and Tylenol.
Yeah.
See what I'm saying? I don't know.
Can I make a comment? Certainly I use continuous oral contraceptive pill, and even we'll try that first line to try to mitigate the effects. But what I do find, just anecdotally, I don't think there's evidence or comments around this, but when the oral contraceptive is taken continuously, there can be a phenomenon of breakthrough bleeding and cramping around that, and because that's not predictable, it just can be difficult. But it doesn't mean that it's not worth a try. But I do tell families to watch as soon as they see some breakthrough bleeding. Decide if you're going to take a break and have a period or not, but regardless, start an anti-inflammatory at that time, especially if it seems to correlate with behavior. And again, so the tracking is so important, whether it's breakthrough bleeding or a full-blown period that we're monitoring to look at the correlation with behavior. Certainly, we use continuous oral contraceptive, though.
All right, so So, another problem solved, because after giving regular naproxen, starting several days prior to the menstrual cycle, along with, let's say 2 days prior to the menstrual cycle, along with also starting the oral contraceptive pill to help ease Susan's difficulties around her period, we've noticed some improvement. But then Susan comes in to have her blood pressure checked and her contraceptives renewed. Her mother lets you know that the pediatrician cannot see her anymore as she's turned 18. Her pediatric neurologist also discharged her at the time of the last appointment and suggested that she'd be referred to adult neurology. The pediatric mental health team has also indicated that they cannot see Susan one more time. They can only see Susan one more time, and then a referral should be placed to an adult mental health team. The wait time for the adult dual diagnosis team is 12 to 18 months. So, how could we have optimized the transfer of care from pediatric to adult health care? So, yes. So, a lot of what we're seeing here is a transfer of care. It's the hard line from where you move from the pediatric system to the adult system, the end. But what would have been ideal is an actual transition, which is a purposeful and planned movement over time from the pediatric system to the adult system. So if we were in this situation now, what do we do? No ideas?
Make sure that you have a very good summary from your pediatric physician when you are picking maybe the family physician, to have the continuum of care before the adult team come in. Right?
Start to ask for so the hard records, the paper stuff, maybe contacting for some in-person or a telephone discussion, perhaps asking politely, is it okay if we liaise for a little while after I take over care so I can call you back? I've done that with a couple pediatricians, very helpful, especially since they know them so well. It's been 18 years and you're picking up sort of out of the blue sometimes. What other things could we have done? So, age 17, we met her. What could have been done over the years to improve this point in her health cycle? Sorry, that was a read my mind question. We've been doing a little bit of this. We've been providing care intermittently here and there for many of her healthcare issues, but we could have known her all along because we are a family physician. So having some contact with her over the years so that it's not a surprise when she turns 18 and arrives at your doorstep is very important. And what about this, for example, the neurology? So the pediatric neurologist discharged her, so she doesn't have a neurologist anymore. How do you feel about specialist to specialist transition or transfer of care? Do you usually get involved in that? Are you the one making the referral? Do you prefer the specialist to do so? This is just a point of discussion, I'm wondering.
I just find that there is a gap in that way, that the cardiologists seem to have that in better motion in their nursing practice, that kids gone from Toronto General or something, or from sick kids, they automatically transition nicely to an adult cardiologist, no problem, and not the same. So I think it's sort of communications from their point of view, developing a better system.
Mm-hmm.
Should there be like a data care or something like consistent? I mean, that's, follows through a short time from the time that she's growing into that full an adult, so there should be something in place. And who's advocating for her? What does mom, the kind of multidisciplinary team that's working with mom, they should have find that information and having an exchange, so that's
Mm-hmm. So, I mean, some people are really lucky to live in big cities where there are even transition clinics, for example. So then they'll pop into the clinic, they do all of this stuff and recognize, oh, you're in neurology, they don't do this automatically, let's make sure that that gets done, but some other folks are more on their own. And so that's in that case, it might be the family doctor who is highlighting that, oh, I realize that you have these specialists, are we going to need an adult equivalent? And I think that highlights again some differences between the pediatric and the adult healthcare systems, right? In the pediatric system, I think not only are they maybe followed a little bit more, they're in more teams, they have more specialists available to them who are aware of the needs of people with autism, and then in the adult system, it becomes much more sparse and quite difficult. Just as we say, it's difficult to find a family physician who feels, feels like they have excellent skills in this area. It's probably quite similar for many of the specialists as well, right? So I guess there is that consideration. Do we need the adult equivalent, or do we not? What do you guys think? Do you always get the... So say she's saying, okay, I have a pediatric neurologist. Do I need an adult neurologist?
Because wait times are so long where I practice, we get to get a feel for what it's like to not have the specialist for a while. So, and also sometimes they're seen once and then discharged back to my care. Yeah.
Yeah. All right. So that being said, I'm Dr. Niel. I'm a family doctor. During my extra year of training, or just afterwards, I started working on a transition readiness checklist. It's a questionnaire that's designed to assess the healthcare skills of the youth with developmental disabilities. It was based on developmental disabilities, but I think that a lot of the information there is applicable to youth with autism spectrum disorders as well. So the youth and their caregiver. So the youth and the caregiver will complete the questionnaire together, and the physician hopefully too, if they can. And the tool looks at 4 different health skill areas: knowledge of health conditions, taking charge of health conditions, medication treatment, taking charge at the doctor's office, daily living skills, and thinking about the future. And so this was designed by myself, Jessica Wood, who was a PhD student at the time, and Maureen Kelly, all under the tutelage of Dr. Sullivan as part of the primary care initiative. And the tool is available on the Surrey Place website if you're looking for it. So this is one section of the tool. It's called the Knowledge of Health Conditions, Medication, and Treatment section. So the checklist contains 29 questions, and for each question assesses a skill that's required for a strong partnership between the patient with autism and their caregiver and family physician. And it was modeled after the IWK readiness checklist that they use at their transition clinic in Halifax, as well as a checklist used by the Good to Go clinic. It's a transition readiness checklist from the clinic at Sick Kids in Toronto. And then there were a couple others that we used some input from, one in New York and another one at the University of Washington. In any case, ours is a little bit different. At the top, it says, sorry, it's kind of tiny, so I'll highlight it for you. So this box says, yes, I do this. The next one says, I am learning how to do this. Next says, I need to learn how. And then, I need someone to help me with this. Who? And the last box is, does not apply to me. We added the caregiver into this checklist, which is a little bit unique, because we wanted it to be something that is applicable to people with all levels of ability, and it also can highlight if the caregiver has some skill needs as well. So it's possible that the caregiver doesn't know how to do that either, and so we can start to work on that. Also, you'll see we've blacked out does not apply to me, and so there are some skill areas that that should apply to everyone with a disability or with autism, and it means that if the youth themselves cannot do it, then their caregiver really needs to know how to do that. Oh, and I left there's like a little box at the bottom where you can write all what your plans are, etc. So that's the first section. The next section it's tiny, but you can take a peek at the actual checklist and see what it says. But it says taking charge of healthcare conditions, medication, and treatment. And so this is another one of the big sections. So what's also unique about this is that it's actually linked to a toolkit. So we have the checklist where you're helping to assess what needs you may have, but then we build on the checklist by matching the skills on there with tools. So in the toolkit, for example, question number 16 says, I carry my health card in my wallet and bring important health information with me to doctor's appointments or the emergency department. So that's the skill that we're looking for. And you may have checked the box saying, I need help to learn how to do this. So here in the next box, we talk about a little bit more in detail about the skills that are needed. And then there's a box of tools. So tools that have a happy smiley face are designed specifically for the youth to use. And then tools that are the fancy purple swirl are quite good for caregivers, more specifically. And we tried to include tools that were easily accessible, free, mostly web-based, so you just click on it and you can get it right there. It's not comprehensive at all, and we did that on purpose because we kind of wanted to just get a few tools that are useful, but there are many, many, and in fact, if you kind of use this as an example or an idea, you could include your favorite tools in the different areas and help to build your own repertoire for this area. Here's an example of a tool. We say that all the time, tools. I hope you know what we're talking about. This is something that we designed. It's called the Portable Patient Profile. It's actually modeled after a cumulative patient profile, which is also on the Surrey Place website, and in that orange book that was created by the Primary Care Initiative. But this one's a bit shorter. It's a two-pager, and it just summarizes some of the healthcare information that might be useful to carry with you, or when you go to see a new specialist or a different doctor, for example. At the top, what are your main health problems, level of adaptive functioning, cause of disability, allergies, medications, just simple stuff that is. It sounds so easy, but if you have this, it makes a big difference. If you go to see the new neurologist, for example, they might like to see this paper. There's the back, and we have some areas that kind of speak to their level of adaptive functioning, their levels of disability, and different things like this, so that people can understand your baseline. So the toolkit does have a few strengths, I think, but it provides a method of assessment and has tools that match with it. It's pretty brief, so should be quick enough to look at. The tools are accessible and available online and free. Many of the tools are good for the youth to use themselves, and many of the tools are Canadian, and many of them are evidence-based. It is very health-oriented. It is sort of based on developmental disabilities, so not specifically autism, and it's certainly not exhaustive. And it has not been formally evaluated. There are ways to further validate the questions, and maybe you can condense the toolkit and that sort of thing, which we haven't had yet done. But I think for now, it's a start. Good place to start, right? Here's another tool that we included in the toolkit, so it's at the back. It's a little bit something slightly different, but it talks about how to make a healthcare binder. And I think this might be a good project for, there are those caregivers who are like super organized, and but they have all the papers, and they have it like a little bit messed up, and not quite sure what they're looking for, but they have it in their pile, and this would be the opportunity for them to get that all ready and organized, especially as they're trying to meet new providers. And so that gives you some ideas of good headings that might be helpful to use, maybe some tools to summarize information instead of keeping all the loose pieces of paper, and which papers are really actually important. And here's another tool that's called a transportation scheduler. So there's one about, do I know how to get to my medical appointments? And it actually outlines in detail how to do that. You plan who you're going to call, and then have the phone number, and then what do you do, and what time is the appointment, and all of that stuff. So there you go.
Alrighty, so we're doing well here. We're on time, and we're at the last part of the case here. So I hope this highlights just how great it is to be a family doctor, this last part, because you see Susan and her mother in follow-up after working through the transition tool. And Susan's been doing fairly well, although she's started to struggle a little bit with sleep issues, more so than baseline. And as you proceed through the appointment, quite intuitively, because you've known her mother for some years, you notice that she's less talkative than her normal self. Her voice is quieter, and she certainly seems less animated. She's also not brought her normal list of questions and her observations or calendar tracking that is characteristic, is normal for her to bring to her appointments. What questions or concerns do you have at this stage for the family?
Screening for depression.
Great.
Inquiring about relationship or financial difficulties.
Excellent. Yeah.
Maybe inquiring about what she's concerned about as her child transitions to an adult.
Great. Excellent. All the key questions, and we're in a great position to ask them and to be able to follow up as well, knowing patients. So it's great. Oh, it's important, yeah. Thinking about life stage and the fact that you know her helps as well. Able to provide that wraparound care for the family. What treatments would you suggest, or what next steps would you suggest? So we're asking the right questions, we're thinking of the right things. Is this an area where you feel resources are lacking?
I'm just, again, I'm your own doctor, but I wouldn't just assume that she's probably depressed. I would probably look at, she's spending all her time taking data, dealing with behaviors,
Great,
driving her
yeah.
around. Is she eating lunch? Is she going to bed?
Yeah.
Right? Like, does
Exactly.
she have low iron or something? You know what I mean? Like,
Yeah.
maybe it's everything. She's just
Yeah.
not looked after herself. She's all about Susan, and now she's just,
Yep. Yeah.
I mean,
Exactly. Exactly. And the opportunity to flesh that out. Exactly. And to always, of course, it's a very important reminder to think of the physical things first, the medical issues. Is she iron deficient? Is she perimenopausal, etc.? Invite those questions.
And I would also look into area relief, some social, area relief for the mom.
Yeah.
You're transitioning, right now, she have a good transitioning
Yes.
out
Yes.
for Susan. However, Susan will be leaving school, right? Educated Susan,
Exactly. Yeah.
departure refer mom out to some social services agencies.
No, that's right. She realizing that this transition is going to be a lot harder than she anticipated, potentially in terms of meaningful daytime activities for her daughter, feeling overwhelmed. Great suggestions. So these are some of the things that come to mind in terms of caregiver burnout or needs, or just being more attentive to caregivers. And it's recommended that we screen for this as well in our practices. Dr. McDougall talked about, parents who he sees in his practice, just being that step away from tears welling up in their eyes, etc. We're in a position to be able to really provide wraparound care, since we care for families in family medicine. So thinking about sleep and appetite, functioning, missed activities, and self-care, or overt signs of depression are all things that we should be just thinking about and using, again, our intuition. Is this person seeming different than I've seen them last, or should I inquire about this directly and make the time and space to be able to hear the response? And exactly looking at what supports are feasible. Is respite care an option, and or counseling? And certainly, of course, is there any kind of safety risk for the individual? So here's some resources. So dual diagnosis teams are a resource in terms of referral for mental health issues in adulthood. Community Care Access Center may be able to help, although the help is limited, but may be able to help with some needs around showering, some basic supports, but again, it can be pretty limited. Going through the Developmental Services Ontario process, if that's not started, is important to mention. And I see some that resonating that is a long and involved process for patients, but can be a source for respite care funding. It's something that not all physicians are aware of are the healthcare facilitators of the community networks for specialized care. So that's in your handouts. If you just Google that, you'll be able to find a representative for your region. These are typically social workers or nurses funded through the Ministry of Community and Social Services, meant to help us navigate to what developmental service options there are in our area, and so can be a great resource, especially because we function in two different sectors, so we're often quite familiar with the equivalent resources for our vulnerable elderly populations, because it's all housed in the Ministry of Health, whereas this group, because it's housed in another ministry, we're not always that familiar with. So excellent one-stop place to go if you have questions, so I'd encourage that. And then we've added Health Links Ontario here. Anyone familiar with and using Health Links? Care plans for their patients at all? It's still emerging. This is a program of the Ministry of Health meant to provide care plans for complex patients. So more to that, as that seems to be an area that the ministry is investing in. And then I can't recommend enough the Autism Speaks resources for family. Their toolkits are also very helpful, and there may be odds and ends that you would find there as well in terms of explaining menstrual care or other issues around hygiene, etc., to help for parents with their children with autism. This is a list of sort of special resources that we feel would be helpful for family physicians. So this is right now blank, and it's a tool of advocacy that we are presenting to our various community networks of specialized care and other regional resources, saying family physicians need to know all of this. People who are interested in seeing our patients in adulthood in these areas, or the names of agencies or resource contacts, etc., for our patients. We need it all on one page, and we need fax numbers, and it needs to be fast. So we're advocating to try and put together these types of regional resources. So I'm sorry that it's not filled with all of what you need in your region, but people had mentioned resources, and I wanted to mention that this was an initiative that we've really worked hard to try and isolate the people who we need and work with those who would be able to identify those specialists and other resources for us and keep it updated. So not just medical, but sensory integration assessments, ADLs, swallowing, special education, developmental service, vocational programming, recreational programming, etc., where can be a point of contact for us in supporting our patients in this regard. So we're coming to the end here. Everyone's been wonderful participating and engaging in this discussion. So I'm just going to walk you through what is page 2 when you have a chance to go to the Autism Health Watch table. This is essentially a checklist for what you would do at an annual health check. So we think about, in blue here, preparing for the office visit. Are there needs that the patient or caregiver has that they can identify prior to the visit? And is our office set up in a way that is accommodating? I have patients with autism who, at this time, they may eventually work up to entering and sitting in the waiting room, but they do use entrance in the back of the clinic and are able to go right to the waiting room that is ready for them, and the lights are turned off and there's ambient light coming through the windows in the room, and it's a much quieter and autism-friendly environment for them, and it makes the appointment much more feasible. So there's little things that we can do pretty easily in our clinics. And then going down our checklist, is there a need for genetic reappraisal? Have we thought about hearing and vision? And I'll just put dental there as well, because I always think about that. Do we need to review and think about seizures, or are there epileptic medications that we need to be monitoring levels for, doing blood work? Have we thought about gastrointestinal issues? Have we thought about sleep? All of these things are outlined here, and that's it. So it is, it is a number of items, but we can check them off as we go along. If we think about them systematically this way, we're really providing the wraparound care that we need. So back, last slides here to the patient's medical home. What was our take on it? And I encourage us all to contribute to this effort. And I really, if I were to say, what would you advocate along in family medicine that's going to have national scope and impact? It would be the College of Family Physicians' vision for patient's medical home. So what should we be thinking about for autism? Not just patient-centered, but person-centered. Is the autism, do we have an autism-friendly clinic environment for this individual? We need to not only ensure that people have a family physician, but we need to involve that family physician and team during the pediatric years so that we have, exactly as Dr. Niel described, a transition rather than an abrupt transfer. We need to offer broad scopes of services and teams, and we need a special kind of team. And although we may not be able to logistically have everyone on site, we need facilitated, efficient access to behavioral therapists and other specialists that may be outside of the traditional family health team model. In terms of access to appointments and advocacy for specialist appointments, it needs to be easy for patients to book an appointment. It may be difficult to remember an appointment. They may need to be able to drop in and be seen, and we need to accommodate that. And we certainly need to advocate for shorter wait times and to have some interim strategies that we feel we can comfortably manage with patients while we are waiting. We need to provide a full comprehensive scope of family practice services, and we would advocate for the use of the Autism Health Watch table in order to provide treatment that is comprehensive in the scope of this, this disorder. And there is, I've put here, there is evidence, there's lacking evidence in the general population to do annual physicals, and that will be a message that's coming out, and people are hearing more and more from the results of a review of the Preventative Healthcare Task Force of Canada. There is actually evidence for individuals with developmental disabilities that an annual health review with physical examination does change health outcomes. And so we really recommend that we not lose that piece for this population. The rates of undetected illness that we find in doing these regular reviews does actually hold some weight, and these are out of big studies that have come out of the United Kingdom. Providing continuity of care and relationships, and we've just highlighted here that the doctor-patient relationship is strengthened by understanding and accommodating the social communicative differences. This is an area that can be so rewarding that instead of becoming, feeling that these differences provide obstacles in communication, when we develop ways of accommodating and working well with communication differences, we become such a resource to the individual. EMRs are important. For our patients, they are essential records of previous things that have been tried, what their actual health problems are, and sharing information electronically is of great benefit. And so they are particularly important to have the option to use, access this technology. I'd encourage people here who are teachers and people here who are parents or self-advocates to join us in contributing to teaching medical trainees and to research in this area. It's very important. As you could see, the dearth of studies in adulthood. We need to know more, and so participation as clinicians and as patients in teaching and research is very important. When we look at quality indicators, what should we be looking at in terms of quality? How often do we do an annual health review? Is that something that we should measure? Should we look at our rates of psychotropic prescribing in this population? Some key questions that we actually have some big Ontario data coming forward with a cohort of 60,000 adults with developmental disabilities through the H-Card project, and the link is there for that as well. And lastly, we need support, and it's important that governments and stakeholders all recognize the additional time and effort but benefit of creating accessible primary care medical homes for people with ASD. So we just have some resources here, and they're in your slides. And I'll just thank and highlight the importance of individuals with ASD. I hope that there's lots of blogs on and reports on getting, employment or managing going out to a restaurant, etc. I really hope people start to write about a trip to your family physician and what could be better in that indication, and we'd be more informed that way. Okay, thanks everyone.